right, welcome everyone. Welcome back. Healthcare organizations need to successfully leverage and integrate the latest technologies to stay ahead of the competition and efficiently drive operations. This panel will discuss a few different topics. How healthcare companies can transform their operations to meet the changing needs of patients, how they can use technologies to enable patient wellness and improved health outcomes for members, and balance the use of technology with the human factor in the patient-centered approach. And we'll also talk about how do you overcome the challenges associated to implementing these. That said, we've had an exciting few years in healthcare with innovations at the early stage of dramatic change. Since COVID, the telemedicine rates have skyrocketed, remote patient support has sort of become commonplace. There's heavy emphasis on continuity of care and the end-to-end patient experience for both providers and physicians and hospital systems. And we've said this in other panels that I've done in the past, but the lines between the payer side of the US healthcare and the provider side are starting to blur a little bit. And that means both are taking on a level of measurable accountability for patient and member outcomes. And at this intersection, there's a few different topics we'll crack open today. One of them is value-based care. Those of you who don't work in healthcare, you'll learn what value-based care is. Those of you who do, we'll crack that topic open. We'll talk a little bit about the innovations that are happening in revenue cycle management and payment integrity. We'll talk about pricing transparency. Yesterday, one of the panel speakers talked about how the members and patients are disconnected from the cost of services, right? So how do we make that transparent for members and create better accountability for patient and member experience over the course of a lifetime rather than a single transactional visit? So all of this, you'd think there's competing interests, a little bit of the cost versus quality debate that's been going on, but that's not really what we've discovered is happening. There's the ability to potentially deliver better outcomes while also reducing the cost at the exact same time. The two are not competing with each other. And we'll also talk a little bit about applications and how mobile apps are doing everything from network providers to searching, to scheduling, to booking, to follow-up and maintenance and telemedicine. And of course, we wouldn't be a panel here today if we weren't talking about ChatGPT. So we will crack that open, and there's products like that that are showing real-world benefit, and more importantly, they're convincing consumers that this actual benefit has practical use in their lives, both from their wallet's perspective as well as their wellness perspective. And if you can imagine the possibility of an AI-based chatbot that's combined with the visual overlay and the voice overlay, what that could potentially do long-term for healthcare is pretty astounding to think about. Not only will efficiency be realized, but better and more expedited care outcomes will now be a possibility. Today, we'll crack open a few of these topics, both from a payer and a provider point of view, and we'll see what some of the most influential insiders in this industry think is coming. So let me introduce our panel. So let's start off with Mark Brooks. Mark Brooks is the Chief Transformation and Technology Officer at Centene. Luke Rockenbach, who is the Chief Transformation Officer Revenue Cycle for Providence Health. And Kimberly Sullivan, the Senior Vice President and Chief Revenue Officer for Peace Health. So welcome everyone.
Thank you.
By the way, thank you for joining us. So let's start off with a topic that fits on both sides of the equation in US healthcare. We started off with value-based care. So maybe for the people out here who don't know what that is, a little bit of an overview. Kimberly, I'll start with you on what that is and what you're seeing, how that's changing how you guys are approaching care.
Yeah, I think of value-based care as caring for a member through his or her lifetime. And so it's moving from that episodic to total care of a patient. What I'm seeing in the industry over the last few years is a real increase in the physician appetite to participate in value-based care models. I'm also seeing a steep investment on the provider side in building network adequacy. So you need the right blend of providers within a geography in order to provide that whole care for the patients. I'm seeing in markets where it is value-based care is emerging, or states where it's emerging, the payers are really scrambling to gain that market share and also to reestablish their provider relationships with their most strategic partners. And then finally, I'm seeing a lot of interoperability and investment in data analytics, because to treat a patient, if you think of a provider, I work for a health system that's 10 hospitals and over 1,000 clinicians, but we only have a portion of what the patient's experience has been in healthcare, and most of that lives with the payer. So a lot of data sharing now so that we're operating off the same information to provide the best care to the patients.
Wow. Luke, you live and breathe this every day. You want to give a little bit of your point of view from this at Providence?
Yeah, all the things that Kim has shared on value-based care, I see it as taking care of the person for their life. Everyone needs health care, beginning of life, end of life, but then these moments throughout your experience, and you don't engage with it every single day. So when we think about managing a population of folks, keeping a community healthier, I think it's important to set up the incentives both throughout the health system infrastructure, but also with the payers, and even with employers who often fund so much of the healthcare journey. So, as we're seeing kind of more and more direct to employer, we're seeing more engagement with the payer, and then of course, the investments within the health system to get better at coordinating that care.
Great. Mark, Centene's got the largest Medicaid presence in the United States. Is this a component of the strategy that's being deployed by payers, and can you talk a little bit about that?
Yeah, absolutely. Agree with my fellow panelists around total care and the life cycle component of a value-based arrangement. But we also see it as the largest Medicaid health plan in the country as a way to build relationships with our provider partners. Mm-hmm. So value-based care done correctly gives us an opportunity to help our provider partners provide a more elegant care experience for our members in the way in which we agree to remunerate our provider partners for specific types of services with a goal of reducing administrative burden and taking costs out of the system. And a great example of that is our provider partnership. So Medicaid services are delivered by a variety of different health systems, but one of the key delivery partners are FQHCs, Federally Qualified Health Centers.
Yeah.
And FQHCs tend to be running on a bit more of a shoestring budget than a lot of the major systems. So we've created, in the state of California, as an example, in the Medi-Cal program, we've created value-based arrangements that not only share risk and allow us to make sure that FQHCs aren't burdened with inappropriate risk, but provide cash flow in the form of capitation, which is helpful for them to kind of maintain continuity of operations and facilities that support member care. So not suggesting that the wall that has existed between payer and provider isn't still there, but I think CMS really pushing us aggressively to find common ground in these relationships, and then the market really kind of turning in that direction is a real opportunity for the industry.
Yeah, great. And Luke, with your role as Chief Transformation Officer at Providence, talk to me about the revenue cycle management, and you may want to educate the audience on what that means, but it's more or less the collection side of the hospital systems.
Yeah, it's the revenue cycle team within any health system or hospital. Their job is to get reimbursed for the good clinical work that happens, and it really starts at the point of registration. Then clinical care is provided. There's charging and coding and capturing all the activity, and then it gets into billing, and that's where the payer provider engaged, and we get reimbursed, and we have all kinds of policies and rules that we have to work with, and the wall is still there, but over the last 6 months, I've spent more time with payers than I've ever had in my career, because it's so important for us to actually look each other in the eye and say, this isn't working for me, I know it's not working for you, can we solve something?
Yeah.
Well, and we're a lot of fun, too.
Also, they're a lot of fun.
Kimberly, over to you.
What I would say over the last 5 years is I've seen health systems invest so much more in the revenue cycle patient experience. And so the genesis of that was as costs were shifting to the patients, we were setting up new systems and ways to communicate effectively, enhance their experience. I'm going to borrow from or amplify what one of the panel speakers said yesterday about digital experience. That's table stakes for us in patient experience. And then we need to be able to meaningfully replace the live experience with the customer with that digital experience. And so a lot of investment in that. I'll give one really good example. The organization I worked for before, Peace Health, operated a contact center that had over 1.2 million calls annually from the patients after care. So it wasn't clinically oriented. It was, how do I pay my bill? How do I get online? The gamut was pretty wide, and we implemented listening and really started to catalog, why are we getting 1.2 million calls a year from patients? What can we do better? And we found that almost 30% of those patients tried to solve their problem digitally first, going online, and failed, and so therefore had to call into our call center. So again, so much investment in increasing and enhancing that patient experience, because we are serving our communities, and we want to retain that patient for life.
Yeah. Mark, so the revenue cycle management, payment integrity is sort of the opposite side of that coin from the payer perspective. Is there anything interesting that's happening there?
There's a lot interesting. There's a huge opportunity. To Luke's point, payment integrity is the payer's processes around taking a claim and ensuring we're paying it to the contract as we interpret it. And that's where things get tough, right? Interpreting the words in a contract and codifying it is not necessarily as straightforward as you might think it is. And we run all kinds of processes that were built in order to ensure that adherence is there, that end up being administratively very inefficient, to Luke's point, starting at registration, right? So our view of that process is we have payer partner or provider partners that literally call our call centers to check eligibility every day for the panel that's coming in to see a doctor. We're happy to do that work, but clearly, in the digital age, there's got to be a more efficient way.
Got to be a better way, yeah.
Or we have processes around what we call SNP controls or SNP levels, which effectively allow us to push claims back to providers if they're not at the right level of detail, which, again, the spirit of it is trying to get to adherence, but it is administratively pretty inefficient. So the way I would like to think about this in putting it through a digital lens is that there's absolutely no reason why that back and forth needs to exist today, and that we should be collaborating to build a solution that eliminates the need for a claim. The program that we're working on this at Centene we call frictionless. And if you really think about it, in fact, I just had an experience. A DoorDash driver ran into my car in my driveway. Yeah. And I had to file a claim with my insurance company. And it was really interesting in that the exchange between the insurance company and the shop that was going to fix the dent was completely electronic and seamless. Like, I didn't even have to get involved in the conversation between the two. And it's just baffling to me that in our industry, that same connectivity doesn't exist.
Yeah.
Can I go on for one more minute?
Yeah, of course.
So
one more.
So I get a little bit excited about
off.
this, but so in my mind, there's absolutely no reason why a member shouldn't be able to walk into a provider's office with his or her Centene ID card, have the person at the front desk swipe that card to verify eligibility, at the same time initiate a transaction that collects the copay from that member's HSA in a partnership with MasterCard, or Visa or American Express behind the scenes. Once data is collected loosely from the EMR or from historic claims data, and we've done checks for HEDIS and risk adjustment and administered care based on those checks that happen with AI.
Yeah.
Or verified via chat GPT, I got to get that in there.
Yep, of course.
A record is sent back to the front desk that captures ICD and CPT, and we pay immediately the provider whatever we owe in the construct of a value-based agreement. All of the mechanics, all of the technology necessary to accomplish that exists today, right? We just haven't broken the bridge yet.
To piece each one of those items together to make sure that that works. And in a physician office setting, I think it's very possible to make those things connected. In the inpatient setting, where you're navigating many different challenges, would love to aspire to get there. Love to aspire to a spot where we have some kind of a capitation or risk-based or quality incentives versus just the more I do, the more I get
Agreed.
paid.
Yeah.
And you've taken the payment a step further. I've worked with a major payer in California, and their strategic goal is to adjudicate a claim within 90 seconds after service. It wasn't to pay it, but it was to adjudicate it so we would know, the patient would understand what their financial liability was. So I appreciate everyone working to remove the friction.
So we touched on sort of member and patient experience. And the reason I say those things together is because you usually hear about member experience and you usually hear about patient experience, but really the seamless experience requires both parties to be a part of that equation. So there's a few topics I want to crack open here. One of them sort of aligns to what we've already been talking about. Price transparency, it's a big thing. Obviously, consumers are demanding it. There's solutions being developed to make those costs more clear to the consumer. Kimberly, any thoughts on this from a provider point of view?
Matt, I don't know if you've ever heard this saying, speaks easy, does hard. Pricing transparency is so much harder than it needs to be, so many different variables. What I will say, in my personal opinion, the legislation that's come out recently that in no way helps the consumer. Health system posting 90,000 lines of its charging schedule, as well as 50 different payer contracts and what they may pay for a service, does nothing for the consumer. We have to get better at anticipating what services are going to be provided, and it changes when the patient gets through the doors of a hospital. And then having that conversation with the patient or sending them that information. I don't want to imply that it has to be we're picking up the phone.
Yeah.
But really, consumers are getting smarter every day. They know they have options to shop around. We need to be providing them with the best level of service.
Luke, you probably think about this a lot. I imagine you have some reflections on this one.
Yeah, absolutely. Just to add to the patient experience, it's further complicated based on where someone may be at with their health plan. Let's just say somebody has a high deductible health plan. Their personal out-of-pocket is going to be very different at different points of the year as they experience different health care. You could be at the exact same office visit in January. Their personal liability is different than it is in December based on other factors. So the partnership and the education with the patient is so critical. And while the price estimates give us a starting point for that, we've got to invest in the frontline caregivers so that they are able to do that education and really bring patients members along. And I think the payers could be right there with us on that, helping the membership understand how their plans work.
Yeah. Mark, I know you think a lot about how technology can benefit the member experience side of things. Can you tell me, is there anything interesting you're seeing, any technologies that really interest you or are peaking right now that are attractive?
Yeah. I hesitate to jump on the AI train right now, but it is an interesting capability that I think can be deployed pretty broadly in the industry. And the area that I think has a lot of potential. So the 2021 rules by CMS and ONC around interoperability have effectively asked payers and providers to put a huge wealth of data in the digital ecosystem and make it available in a secure way to parties that are intended to leverage it to improve member-patient care. And I think what that should allow us to do is to effectively build AI models that look for patterns in disease or patterns in care in order to trigger preventative or proactive interventions. I think we're at a point where those AI models are able to be trained across broad types of data, EMR data that is structured and unstructured, and our claims data or our authorizations data, and would be able to join that information and draw some pretty exciting conclusions. So to me, that's an area where I think will really evolve the experience.
So Luke and Kimberly, we talked about continuity of care a little bit earlier, at least I touched on it. Want to talk a little bit, am I right that the focus on the lifetime of care is becoming more and more the effort rather than transactional or episodic care?
I'd say that's absolutely true because I work in not-for-profit Catholic community-based care. That's always been our desire, but we're expanding from just being an acute system or physician medical practices to include behavioral health and home health and retail pharmacy. So absolutely, it is part of our mission, but it's just accelerating.
Accelerating investments have been happening for years. I still think it's a very small portion of the entire ecosystem today.
Yeah.
I think our chief executive, Providence, recently said we aspire to get to a 30% kind of value-based percent of care. I think we're like at 5% or something right now.
Yeah.
It's there's a big jump to not only get the populations of people to participate in that kind of care, and then the investment to string all of the pieces together, the home health, the acute, the preventative visits, those kinds of things.
Yeah. We talked about sort of the one-stop shop application and mobility and the digital tools. Are those components becoming a bigger, certainly they're a part of Mark's job, but are they a bigger part of your guys' job? Are you engaged in that technology side of the patient experience?
Yeah, they're becoming more and more every day. Scheduling is a great example where you can schedule a haircut from your phone in 2 minutes.
Yep.
And to schedule a doctor's visit, you have to have so many things aligned, including your insurance information's got to be loaded in, and then the doctor has to agree to open their schedule. Those kinds of things are the complicating factors, but that's where the investments are happening. We're seeing some really cool advancements on the patient payment side and the way we engage with patients on their on paying their bill, giving more payment plan options for large balances, those kinds of things, via a digital platform.
I would say one interesting innovation I've seen in the revenue cycle space is, like Luke said, patient payment platforms are becoming more widespread now instead of just using your core EMR's functionalities. But one platform I've seen, they're trying to push patient-specific clinical information about programs you may have in your organization to the patient when they're engaged to pay their bill or view their bill. So it is incredible, because we own all the data, the clinical data and the financial data, to merge them together in order to reach the patient and ensure that they're getting the preventative care and the necessary care, not just the urgent care.
There's a view in government-sponsored healthcare of this activity that kind of co-joins that app experience and some of the non-traditional categories of care. So in the state of Louisiana, our regulator has challenged us to create an app that not only tracks standard care, preventative care, wellness programs, but SDOH. As well, so the quality of housing, the quality of food, and kind of brings that into one member view. It's just a pilot program right now, but I think it symbolizes a direction that we're going to see, at least in the government-sponsored space.
How have you guys seen these things impact the efficiency of care on the provider side? Is it real? Are you seeing real-world efficiency benefits, I guess is what I'm asking.
I think some of the efficiencies that we're seeing in the clinical space, we've brought some tools in that are helping us with charging and documentation, and we have a tool now that listens to the ambient noise in the room while the visit's taking place and is able to essentially create the chart notes. Of course, the physician or provider still signs off on all of that, but those are the kinds of technologies that make a physician able to see more, do more, be more focused on the patient versus focus on the system.
I don't want to lose Mark's point, because one of the greatest benefits of value-based care is identifying those social determinants of health and making sure the population who doesn't have as easy access to care gets access to care. That is incredible for the journey.
So we talked about ChatGPT, and specifically ChatGPT-4. I remember the first time I used it. It wasn't probably that long. I don't know how long it's been. It's probably been 5 months or something like that.
Blank stare.
Since I first used it, I was blown away. It was painfully clear it was not just your next chat bot, right? And the level of information that came out, although maybe a little bit off, it definitely started to convince me of the possibility of the progresses that we're seeing made. So are you guys seeing practical uses of AI technology that are leverageable? Do you see investments that are going to maybe happen in this space? Mark, I'll start with you because you live and breathe this.
Yeah, absolutely. There are a lot of examples of where we're employing AI in the enterprise. The administrative simplification examples are a little bit less sexy, but there's an example around trying to take provider-payer friction out, which is using AI to authorize non-critical services and improving that cycle time around authorizations.
That's the biggest pain point is prior authorizations
Right.
for most members, right? That's the area they feel the pain the most when they have to wait 3 months to get a procedure done.
Right. Going back to the historical crazy, we were authorizing maternity, and the baby's going to come, right? So I don't know that there's a lot of optionality there. So that's a lowest common denominator example. But we're doing a lot of automation there with appropriate oversight. But we've gotten a lot of positive feedback from provider partners there.
You guys are both quasi-technology a little bit. It's hard to escape that. What are you seeing anything change here? Do you think investments that are going to happen here?
Yeah, we're looking at some autonomous coding today, removing the human from the loop entirely. We've got some of that now. It's more of a machine learning tool, but making that jump to AI in that space, I think, can really accelerate that space and make us more efficient. We're also using it for predictive problem solving, helping us know which claim might have a problem with the payer ahead of time, and then using that feedback loop to build rules, fix the process, go work with the payer, whatever the right answer is.
Yeah, not waiting for it to bounce back to you.
Yes.
Kimberly?
I don't have any new use cases to add. I would just say it's been a lot of trial and error, a lot of early failures. In revenue cycle, at least, we're just scratching the surface on what AI can do, and it needs to integrate with your EMR. So that, I think, right now is one of the biggest challenges we face.
I'm supposed to do a lightning round, so we're going to do some fast questions here. Mark, what keeps you up at night? Is there anything what do you worry about the most in this space?
Well, I mean, I would start at kind of the top. I feel like we have a national problem around cost and quality, and I think that there's a lot of activity intended to try and help to solve the problem, but I don't see a single, organized, focused approach that can generate an outcome. Yeah. And so I think a lot about that. In fact, at a personal level, I transitioned my career from technology into healthcare 25 years ago in order to be part of solving that problem. My wife was a nurse at Kaiser Permanente in California, and she said, you just can't believe the stuff that we have to do and the documentation, and come help. And I genuinely kind of transitioned my career to do that. And I think we've made a lot of progress, and I think there's a lot of encouragement in the technologies that are available today, the data sharing that is available. I don't see the right organized approach to solving the problem.
Luke, you're next. What keeps you up at night?
Well, I'm thinking the larger health system beyond the revenue cycle. There's people in our communities that are not being served today. There's challenges just getting to an appointment, make an appointment. It can be very intimidating sometimes to work with health systems. So I want to solve the revenue cycle problems and the process problems so that we create easier pathways for the poor and vulnerable to get in and get the care that they need.
And I would just go back to Mark's original point, like getting the friction out of the system and the nonsensical friction. We've had many conversations with payers where we talk about getting a prior authorization. We put it on the claim, we submit the claim, it gets denied for no auth, and then we have to prove that we got the auth from the party that gave us the auth. I mean, those things just need to be simplified. And then not related to technology or this conversation at all, but what's been keeping me up at night is with the end of the public health emergency, every Medicaid patient needs to re-enroll over the course of the next 12 months. And Medicaid enrollment grew almost somewhere between 20 and 30% over the course of the last 2 years. And so I'm worried about those patients who don't know how to engage because they got a mailer or a postcard, or who will no longer qualify and then need to find other means to get health coverage.
And Mark, it seems like every technology company, as well as their dog, is entering, at least in some way, leaning into the healthcare space. So you got companies like Amazon who have sort of tried and maybe not had the full traction that people thought they would have. You have Microsoft, you've got Salesforce, you've got Pega doing big platform investments. Is there anything there that's changing the game at all?
I mean, I think there is. I think when you have pure tech companies enter the space, they bring a different perspective and they bring quicker development cycles, quicker pure technology innovation. I don't know that I'm totally convinced that one of those players is going to be able to digest the complexity of this relationship that we have built over the course of the last 40, 50 years. Yeah. And engineer a way out of it. But I think that they can be a supporting part of the ecosystem.
Okay. So digital health has been a big talk of the town, and for those of you who don't know what we're talking about, there's a lot of digital sort of point solution firms that are delivering care remotely. We talked about the increase of that at the beginning of this call. Livongo in the diabetes space is a really good example of one that scaled pretty quickly. Companies like Hinge that do remote therapeutics using iPhones and devices that are attached to your body. Are you guys seeing anything gain traction on the provider side with those types of solutions? And do you view them more as competition or more as a potential solution that gives you better opportunity to deliver to patients?
I've seen one successful maternity care application. What worries me is everyone's going after...
Is it Progeny? Progeny has a pretty interesting there in maternity
It
care.
wasn't. It was an internal Providence app that they built and spun off. But it's all about user adoption. Does it serve the members' needs, and will they use it for medical management?
I think the pandemic accelerated telemedicine in a way that was really needed. Telemedicine isn't new. The VA's been doing it since 1970. But I think in normalizing a doctor's visit on your phone or on your computer, I think can really change the game for people getting access that maybe can't get out of their home. And we need more of that. And you mentioned the wearables or the at-home diagnostics. I think that's going to take some investment, and we have to strategically figure out how we place those critical, durable medical pieces of equipment in people's homes that really need them.
Do you guys think an open source strategy to these types of point solutions in the digital space is the winning game, or do you think hospital systems are trying to build their own sort of proprietary solutions?
170-year-old hospital systems are great at innovating.
Not historically, yeah, not historically.
I think we need partners. It's all about partnership, whether it's a partner with a payer, partner with a tech firm, and other. I think that's the answer.
Yeah, I believe open source is the answer as well, and it needs to interface with, there are 3 major EMRs. It needs to be seamless in terms of exchanging clinical data, because that's the source for the provider.
Yeah, you can't be the best at everything. So, Mark, any thoughts? We've got about another minute, and I'll do a little 20-second closing little remarks. But any other thoughts on what we're talking about in the digital care space?
I do think the open source idea is an interesting idea. I had an experience recently that was an alternative to a pure open source. So, an organization called the Peterson Group that I wasn't familiar with prior. It's a not-for-profit funded by BlackRock. Approached me and wanted help building a security model to do IoT across the industry, payer and provider. And I thought that was kind of a neat idea, a not-for-profit trying to be the organizing factor. So maybe there's something like that could help.
Great. So first of all, honored to be sharing the stage with such a distinguished group. I think the next few years are going to prove to be a pretty interesting time. We're going to see different winners and losers. We're going to see probably the cannibalization of solutions sort of happen, and we see what emerges out of this. And how companies embrace technology and leverage that technology is a key determining factor. So I want to thank our panel today. Thank you guys for doing this with us. And also thank you to our audience. Thanks everyone for attending today. Thanks very much.